All right. So, welcome everybody. Thank you for still being here at the end of a long and busy day. I'm very excited to kick off this last session of the day in the Silver Zone, which is looking at best or promising models of care for HIV and aging. And we have a wonderful group of panelists for you today. I'm going to invite them to self introduce as they speak. But I just want to acknowledge Dr. Tristan Barber, who is joining us virtually, who actually convened this panel of speakers. I am just the stand-in moderator for the day. My name's Kate Merzen. I'm the National Program Manager from Realize and co-organizer of the Silver Zone. So the folks on the panel are going to talk about the best approaches to managing aging for people living with HIV in different geographic settings. And they've been asked to sort of explore two overarching questions, which is around how to structure an effective HIV and aging clinic that might be both cost and time effective, and then how to access support when no ancillary services are available in the same space where care is being provided. So I'm just going to invite the panelists to speak in order, starting from that end, if that's all right. So I'll pass over the mic, and each panelist will have a chance to speak, and then we'll have a discussion. So welcome, Brenda.
So first I introduce myself. Okay, so my name is Brenda Crabtree, and I'm in the Instituto Nacional de Ciencias, Médicas y Nutrición. This is based in Mexico City, and we are in a third level clinic. We have an active clinic of more than 2,000 HIV patients, and more than a fourth or more. I'm sorry, it's too noisy, so it's really difficult to concentrate. But more than 27%, around 27% of our population has been aged more than 50 years of age, reached more than 50 years of age, and this has become a major issue and a line of research for us, because we think we have to plan the best way of getting them in the more comprehensive care for people living with HIV that have so special needs because they are aging with HIV. And I don't know if everybody wants to introduce and then, or, yeah, okay.
Hi, everyone. My name's Jenny Hoy. I'm an infectious diseases physician from Melbourne, Australia. We have 9,500 people living with HIV in the state, but my particular hospital is a tertiary hospital where there's statewide HIV service, and we manage about 1,000 patients. Over 50% of our patients are over 50 years of age. Actually, the median age is now getting up to about 57, 58 years. So really an aging population, and many of them have had HIV infection since the late 80s, mid 80s. So that's our clinic. You want me to
Hi, everyone, and thanks for the invitation to join this discussion. My name is Jessica Castilho. I'm an infectious disease physician and researcher in the field of HIV and aging, and I'm based in Nashville, Tennessee, in the U.S. South. Our clinic at Vanderbilt University cares for about 4,000 active patients, about half of whom are over the age of 50. And at our clinic, we're the primary care clinic for providing primary care as well as HIV specialty care for the overwhelming majority of our patients. Our biggest challenge right now in our clinic is probably multimorbidity. And as our patient population has aged, keeping up with all of the comorbidities and really non-infectious health challenges that they're facing is really our greatest need right now.
Hi, good afternoon. My name is Claudia Cortes. I'm an infectious disease from Chile. I work in University of Chile and in Fundación Herrerán, the main, biggest and oldest HIV center in my country. We have currently 6,000 patients. and probably 30% of them are over 50. And we have seen the last 2 years the problem that probably everybody else saw. It's COVID related, and how our patients, specifically this patient, older patient, that were more afraid and they stayed home. So we have to make a plan to deliver the drugs for them. And now they're coming back because we're now start to work in regular and normal basis, or close to normal, to see how they raise weight, why they probably drop many other, the checkup of many other diseases, because everybody was only thinking in COVID. So now we're dealing with hypertension, diabetes, even more than before. That's our current problem.
Hi, my name is Reena. I'm a clinical pharmacist, so slightly different from the profile of the other speakers. And thanks, Tristan, for the invitation. I'm also a researcher in HIV and aging. So a lot of my work is based at the University Malaya Medical Center. We are one of two main tertiary treatment centers in Kuala Lumpur, Malaysia. And we have about 1,800 active patients, and about 30% of them are 50 years and older. But as I say that, I also know that, appreciate that the age of 50 really doesn't mean anything, because lots of comorbidities and issues present much earlier. And so it just seems like, the burden has been increasing over the years. One of our biggest challenges is the fact that our HIV healthcare providers are the primary care providers. So our system is such that our patients come and see the HIV clinicians, and essentially the HIV clinicians are the main providers. So it's sort of expected to do all the screenings and follow-ups and so on. So that's a huge burden, and we just can't cope with that level of work. Yeah.
Thank you. Hi, my name's Julian Falutz. I'm a clinician working at McGill University. Thank you. I consider it a privilege to, I'm a geriatrician and an HIV clinician, and have been for quite some time. We have over 2,500 patients in our clinic, and as Jennifer noted, we've been around for enough time so that our median age is getting close to 60. And as a clinician, what we're trying to do is move away from the identified comorbidities and move more towards thinking about and assessing geriatric syndromes, which we're seeing more and more in this younger population, where antiretrovirals, viral load, all are very good and they're excellent, which is why we are here. And I consider a real privilege to be able to work in both areas.
Hi, I'm Moisés Agosto-Rosario, and I work for the National Minority AIDS Council. I'm the director of treatment, so I'm a public health practitioner. I lead a program on aging and HIV, which is called Strong and Healthy. And though we don't do clinical services or direct services, we work around, what we have done is organize cohorts of people aging with HIV since 2016. So we have at the moment 250 people that are involved in all of our educational activities around aging and HIV. We go from mental health to social services to also clinical issues regarding prevention of comorbidities. That I think it would be for us, we think it's going to be a very important tool to build at the community level, so people, instead of being reactive to it, they start to getting prepared and getting ways to improve their health, so they don't have to be dealing. There is a lot of comorbidities and early comorbidities among the cohort, and that seems to be provide a very high level of anxiety and stress for people that already have lived their whole life going through that process. So I'm here to do more of a community point of view to all of you clinicians.
Thank you. Okay, Giovanni, do you want to go next?
Yes, hello, and I'm sorry I'm not there, let us say in person, but virtually I'm happy to share my experience. And so my name is Giovanni Guaraldi. I'm an ID physician As a clinician, I work in modern HIV metabolic clinic, that is a tertiary level clinic that since 20 years ago actually focused on comorbidities and more recently in aging. And actually what we tried was somehow to reorient our, let us say, health but also social service in a person-centered model of care. And as a researcher, I built up the JEPO cohort, that is a cohort of people aged more than 65 years of age compared to HIV negative control in the country. But more recently, actually, my work is in education and try to fight ageism, especially in people living with HIV.
Thank you so much. And last but not least, Tristan.
Oh, thank you so much. It's lovely to be here with everyone. My name is Tristan Barber. I'm an HIV clinician working at the Royal Free Hospital in London. We're just slightly outside of central London, and we have an older cohort of people living with HIV, I think one of the oldest in London. And I always say that these people are not just chronologically old, they're also HIV old. Many of them were diagnosed before 1996, before we had successful triple antiretroviral therapy. So many of them do have legacy effects of receiving suboptimal treatment, of having had AIDS-defining conditions, socioeconomic and social problems associated with an early diagnosis as well. And this makes them very different to the well-publicized central London cohorts of mainly men who have sex with men, in which we see falling diagnoses and very successful HIV management, very light touch HIV management. And in actual fact, with our older cohort, we've recently, in the last couple of years, developed a bespoke aging and frailty service that was initially only for people that are over 50, but we've removed that age-based cutoff now, and we're taking people with complexity and complex comorbidities and polypharmacy, regardless of age, and indeed also with physical and mobility problems that limit their ability to live healthily. And it's fantastic to be with you all.
Thank you. Okay, so I'm happy for whoever would like to go first to talk about the model of care that you think is most promising to cope with this new, well, relatively new issue of HIV and aging. Anyone want to go first?
Can I go first?
I think so.
Take last in, first out?
Sure thing.
I really enjoyed, we've had a little bit of email discussion, of course, already in advance, and I think it threw up some differences and some similarities. And before we start, I want to also acknowledge that it was difficult to find a speaker in our timelines to be in this group from sub-Saharan Africa. And I think that's a geographical area that's not represented in our group today so well. And I think it's important that we remember we're talking about global models, which of course will really vary according to your country and regional setting. But I think the thing that was similar is the fact that really to look at managing people that are aging with HIV, we need to understand our own local demographic, their own needs, and also be responsive to our own clinical environment. If you work at a center where you manage 5,000 people living with HIV, then you may have the resources to develop bespoke services. But I think what we need to do when we look at a global model of care is think about what the basics need to be. And for me, some of that is about the fact that we have perhaps offered a one-stop, one-size-fits-all perhaps model sometimes in HIV, where we've thought very much about antiretrovirals, engagement into care and suppression. And what we need to do increasingly is think about perhaps our younger patients, but not necessarily, but certainly those more recently diagnosed who may only need antiretroviral therapy, a little bit of psychological support, and a viral load every 6 to 12 months. Certainly we were doing them every 12 months during the pandemic quite successfully. But by understanding those people in our cohorts who can have a stable patient pathway, we should be able to free up time, even if we only have a cohort of 300, to spend some more dedicated time on those with complexity. And I think many of our patients with HIV value their relationship with their HIV clinician very strongly. And I think people sometimes feel unsupported in smaller centres where there's less resource to manage these people with complexity, but actually if you just give them some time and go back to basics and take some very general medical history and examine people, you actually can become a specialist in frailty. So I want to set this up that, you know, some places will have, like as Giovanni does in Modena, very bespoke, very well-developed specialist services. We've been able to do that at the Royal Free, but I think everyone can get involved in managing complexity if they take some time to work out who in their cohort is someone who can have a stable patient pathway and someone who needs a bit more time and a bit more in-depth consultation and support and signposting.
Thank you for that. So on the last in, first out philosophy, Giovanni, you would go next.
Okay, and so I just would like to stress a couple of things. And so what has been said is that we are in a strange time period, because on one side, we realize that aging produces comorbidities, but now we understand that the complexity of agents cannot be, let us say, just how we manage comorbidity is something more. It's what Julian was saying before. It's really geriatric syndrome. And so I think that the very important point is to recognize that this is true not just for people living with HIV, but it's true for any chronic disease condition, because the world is aging. And actually, we need to understand that we've got a great opportunity. We can make HIV be a model of take care of aging in a different way, in a strategy in which we are able to have a person-centered approach, in which the objective is really the ultimate success, that is, make people give value to life. And to do so, actually, it's not just enough I'm able to diagnose cardiovascular disease, to prevent cardiovascular disease, bone disease, but rather, how can I make people be aging successfully? And to do so, I think the point now is really to concentrate on addressing geriatric syndrome, and not as it is, but rather as a way in which we can preserve function. And so I think we need to be very attentive of what WHO is suggesting to move from frailty to intrinsic capacity. That is, try to make people move, be cognitive active, have good social relationship, be, let us say, metabolically healthy, and actually cope all the sensory problem. And so I think the point now is to look at aging as a positive issue and try to make people, let us say, experience healthy aging. I close just to say, in order to do so, the most important thing I believe is necessary is really education. And education starts from the patient first, the people living with HIV first, and the physician. I think that there's a huge burden of ageism. In the talk before, Jules was speaking about the fact that also the junior advocates do not recognize aging as a problem. And so I believe that ageism, that is all the stigma related to this, is very important. We need to fight this kind of stigma that may be institutional, that may be interpersonal, but may be also self-directed. How can I make my person aging with HIV be happy to age? Because the fact that we must tell them that even if you are old, even if you experience comorbidities, you may have a very good quality of life.
Thank you for that. I think that's a really important point. It's come up throughout the day here in the Silver Zone that people are sort of accepting talking about aging because anyone can be aging, but nobody wants to talk about being older. And I think that's internalized ageism, and it's systemic ageism that kind of tends to make people fear that kind of discussion. So who would like to go next?
Okay, so I'm going to tell you about what we've done at the Alfred. So about 10 years ago, we realized people were getting older and we needed to screen for comorbidities. So we told all of our HIV physicians, you know, this is the new expectation, and that didn't work. So we did a quality improvement exercise. We told them how often they were screening, the things that they should be screening for, and then we had some guidelines on when to screen, how to screen, etc. And then we showed they were actually measuring blood pressure for the first time. They were measuring blood pressure but doing nothing about it because they were ID doctors. They didn't know, where should I go with this hypertension? So then we developed some algorithms on initial investigation and management of all of the comorbidities. And that worked for a while until the management became too complex. And so then we developed what we call an HIV complex metabolic clinic. It's a multidisciplinary clinic, very much like Giovanni's. I think it has nutritionists, a pharmacist, nurses, endocrinologist, HIV physician, and a renal physician in it. And so the individuals would come to the clinic and then they would be seen by multiple people and have a number of things addressed, polypharmacy, nutrition, etc. And I think that sort of has worked well. We made it open to not only patients managed at our hospital, but anywhere in Victoria. But now we need to look at a silver aging clinic, not an aging clinic or a geriatric clinic. Patients don't like that word. They prefer silver aging with dignity. And so that's what we're looking at now, that the complex metabolic clinic needs to go another step forward. And we have lots of barriers to that. No space, no funding, not enough clinicians. And I think it is really important because many of our patients are having siloed care. They go see the cardiologist, they go see the surgeon, or the orthopedic surgeon to have their knee replacement. They go see this person. None of those specialists are actually communicating with each other. They might communicate with the GP. The GP does not communicate with us as the primary HIV provider. So communication is so vital. And I think if we have a single place where all of those people can communicate and be part of the team, that would be the ideal for me. And that's what the patients want. And it's also what the GPs want. So that's what I think we should be doing in the future.
Okay, I'm not sure if I'm going to repeat things because I hardly listen to the others, but I understood that you have this clinic with different specialists, but in a developing country with limited research, that's a dream and that's impossible for us. I work in what is classified as a rich or high income country, what is really not true if you go to the reality of my hospital. Even if I work in the main HIV center of my country, we don't have in our side cardiologists or any other specialists. So we need as HIV physicians to learn how to deal with these diseases. So at least if we're not trained enough, we need to train enough to treat them, at least being trained enough and well educated to suspect and to the diagnosis. Because in that way we can move forward and then send the patient to the specialist if it is needed or not. And if this is something more simple, we can do it. But I think Giovanni said it. We're sort of afraid a little bit because we are IDs. We are far away from internal medicine and other specialties. So we need to stop being afraid of that and start thinking about the patient as a whole. But this need to our colleagues to be trained and to break that barrier that we are only paying attention to viral loads and CD4, and that's what we usually do all the time. But this day with the current drugs, we don't need to pay too much attention because most patients are going to be fine and we know they're going to be undetectable. So we now need to move forward and start at least thinking and asking the tests and taking the blood pressure and waiting the patients, that's things that we usually don't do. So probably it's going to take time. So all the colleagues that we treat HIV patients are willing to do that. But I think that's the only way that we as poor countries can handle this.
So I'll give my perspective from where we are in Tennessee in the U.S. South. And where we are, we feel very comfortable. I think all of my fellow providers at our clinic feel like every day is cardiometabolic clinic day in our patient population. And our challenge is that that's really the norm. And so now challenging my fellow clinicians where I am to think not just about a problem list of hypertension and hyperlipidemia, but to push towards concepts around geriatric syndromes and frailty and mobility, to ask about cognitive issues, which patients will bring up, but also ask about things that patients don't bring up, like menopause or social isolation, and recognizing that those need to be up as high on the problem list as the hypertension and diabetes. And my colleagues aren't as comfortable. They don't know how to screen. They don't know how to treat. They can treat high blood pressure and viral load, but are much less comfortable. And how can we start to bring in these concepts and look for these syndromes in our day-to-day clinic, recognizing that the number of patients is just too many to have a single clinic dedicated, because it's the majority of our patients who need this service.
So saying something after you, so in settings with poor resources like we do, for example, I'm in a very specialized institution. I have a geriatric department, which is great, and they are very interested and enthusiastic about our population, but that's not the case for the rest of the country. So I think it's important to measure and do science on what would be the model of care, which is cost effective for most of the settings and also adapted to what is needed in all the settings, because resources, human resources, is what we don't have. We all are aware of what we need to assess, but we cannot do that on a regular basis for all of them, and we are not trained for doing menopause questions or even geriatric assessments, etc. But we realize it's important. So how can we do the next step to evaluate what is cost effective for a clinic that also takes into consideration what people needs, because we have to invite community affected to be part of the discussion, because perhaps we don't realize what it's needed for them. So
Thank you. So I have the issues in UMMC is a mix of what all of y'all have brought up. We are a tertiary center, and so we have access to a geriatrician, mental health physicians, and so on. But they're not many. They're very busy. They also work with a high caseload. We have had engagement with the community to actually ask them what model of care they would prefer. And the large majority would want to see or have all of their HIV and non-HIV related issues assessed and sorted out within the setting of the HIV clinic, because they are most comfortable with that environment. we in Malaysia, we still have quite a bit of healthcare provider or healthcare setting stigma and discrimination. And so, and from prior experience, when you refer them out, they actually don't follow through on their linkage to care. So we also appreciate that. What the model that we need is we probably will need our non-HIV providers to come to our clinic to provide care. We've tried engaging them, and not everyone is agreeable to that. Very often, the response we get is just refer your patients to us and we'll see them. That's not a problem. So they don't quite appreciate or understand the issues of outreach, not wanting to present at their services. So that's one aspect which we are sort of struggling with, and we sort of need to prioritize what needs to be done. Who can we start with first, and perhaps have greater awareness among the different non-HIV providers. The other aspect that is quite a challenge for us is screening tools. For neurocognitive impairment, frailty, and so on, which I come from a multi-ethnic country with 3 main languages. Cultural adaptation, validation of all of these tools it takes a lot of time. And we don't have the expertise to do this, but we know it's really important. And neurocognitive impairment is presenting much earlier in everyone. And getting all of these tools together and convincing our HIV providers that this is the right tool, this is a validated tool, because they are skeptical. Is this tool really working? Should I use it? In one assessment where we use the Montreal Cognitive Assessment, and when we use the standard cutoff, 40% of our patients were impaired, and that didn't make sense. So getting the tools, or at least optimizing the tools for cultural adaptation, language adaptation is also a problem. Yeah.
Thank you.
I just want to acknowledge Tristan and Giovanni. I saw both your hands up. I'll circle back to you, but we're going to hear from Julian first.
Sure, of course.
Thank you. I'd like to pick up on many of the excellent points that have been brought up. I'm getting the increasing impression that what we're seeing is almost 2 opposing views. On the one hand, we have people who are medically, at the time we see them, are generally doing well, at least from the CD4 viral load perspective. On the other hand, we have a saying in medicine: if you don't take a temperature, you don't find a fever. So we have to be proactive, and we have to move beyond asking, what your blood pressure is, and how many people in your family have heart attacks, and your diet, etc. These are all very important. The other problem with that is that if we, in geriatrics especially, and now increasingly HIV, we like doing all sorts of tests and metrics, etc. And that's a problem in terms of communication, because we do various tests and we hand out reviews and everything. And to picking up on the issue of polypharmacy, I coined the phrase a couple of years ago, polydoctory. And I think polydoctory is as much of a problem as polypharmacy, and that leads to communication. And how do we communicate effectively how do we understand what the person's needs are? How do we identify them? How can we be proactive about that? And what Giovanni said about aging successfully, there's a whole science field about how you age successfully, but how do we implement that at the local level? One of the problems with working in an academic hospital is that we like to think of it as one-stop shopping, but people don't want to go there anymore. Many of them are well. They don't want to come to the hospital, especially after the last 2 years of COVID. They've had enough. So how do we outreach that? If we were to do all of the tests that we want to do, we'd have a 3-hour session each time. We can't do that. So how do you fragment that into a logistically feasible way so that you can still keep seeing all the patients that you have to see, but yet you're proactive? So there's competing forces here, and we have to engage not only the person in this process, not only the care providers, but the ancillary, that's a terrible word, all of the other interdisciplinary members, especially the pharmacists, especially the social workers, the nutritionists, and the community. The community, I think, is key, a key player in this, because that speaks to social isolation, which was mentioned, which we're now increasingly recognizing in geriatrics as a huge predictor of outcomes. And we know that persons with HIV are much more likely to be isolated, etc. And that leads to a lot of biological consequences. So there's many competing factors here. And the question is, how do we operationalize them that works for the person who may be in a high-income country or may not be in a high-income country? How do we do that? And this is, I think, part of the important dialogue that we need to have together.
Yes, I think it's all about intersectionalities, how we're going to, like you said, work all these components. And when we talk about the community, I was thinking that, we're talking about how we make it easier for people to age, but you have to understand that this group is not like the HIV negative people that come to age. You come to this phase already with a great deal of trauma, and it's not like suddenly we're going to have a normal aging thing. It's that now we've been told that we're going to have early comorbidities. We've been told that we're going to have multiple comorbidities on top of HIV. And for a group of people that already have gone through something like that in the early ages, is triggering, so it's trauma-informed care. It's understanding where you're coming from. Also, I was thinking that I remember in the early days, and it's give me some deja vu, is like people that were successful in terms of patients, they had to educate themselves, right? There was not many drugs, there were not much research, and we have to jump into learning the science. I mean, I'm not saying everybody has to do that, but like the experience of empowering ourselves to be able to have a dialogue with the doctor, with the tools that allow us to get to a comprehensive place. So I remember the prevention of PCP, the prevention of opportunistic infection, how we did like a national campaign because the community didn't know how to ask about it. So, it's not we want to get people like to be physicians, but to have the tools to have the discussions. So I think the community, when we talk about the communities, it's not only the patients, but it's the people that work with us, that provide the services, so that a community healthcare worker can sit down and say, you should check exercise, but also you should talk about your doctor about the symptoms. And so it's a complete intentional way to involve the community. And this is something that we have already done sort of in the age of OIs and in the time of protease inhibitors as well.
Okay, Giovanni, you had your hand up first.
Yes, and so I would like just to continue what has just been said. And so I agree with Julian also, the fact that so far we did a good job. Let me say, most of elderly people living with HIV have at present even a better care than many other HIV negative control other people. Okay, why? Because actually we were able to work well together with the community. Now we are experiencing a period of time in which both doctors and community are somehow afraid of tackling the aging. And so I look in my situation, my work as a professor of medicine is to train a junior doctor. And it's so difficult now to me to say, well, come in my clinic so that to take care of aging people. As well as Jules was saying, it's so difficult to make a junior, let us say, people living with HIV be focused about the aging issue. And so I believe that the topic here is not that it is incredibly difficult to take some geriatric principle and put inside the HIV medicine. Remember that the task shifting has already been done many times in HIV history. We were able to train people with no education to manage antiretroviral delivery in resource-limited countries in sub-Saharan Africa. And we did an extremely good job. Okay, and so I think that nowadays it's difficult to think that we will have geriatrician to take care of all people living with HIV. No, that's not the point. We needed to have a geriatric attitude. We needed to learn something from geriatrician. But first of all, we needed to have an HIV community be part to understand what the aging issue is, so that to promote successful aging. The point is that how can we turn off this obstacle in which junior doctors don't want to come in HIV clinic, in which junior people living with HIV don't really care about aging. To me, this is really something we need to care about. That is, where is the stigma? Where is the aging stigma? How can we solve this issue? Can we promote intergenerational dialogue? Can we have educational activities for physicians and also for people living with HIV to engage them? Can we stop down some prejudice about ageism, that being old is bad? Being old may be exceptionally good if you are able to give value to life. And so I think we are at the upfront, because what we are experiencing is something that is not just unique for HIV. We can turn to be a model for aging well for all chronic diseases. We did in the past, and we can do it now also.
Thank you, Giovanni. Tristan.
Thank you. So I wanted to just bring this back to what we've started to focus on a little bit, which is about helping coordinate care. So I think I really like Julian's point about polydoctory. What we find is many of our innovations, including develop bespoke services, including giving people questionnaires for mental health, for mood disorders, for sarcopenia, for frailty, for cardiovascular disease. A lot of these benefit people with the most agency, because they're people that can complete these questionnaires. They understand what they're about. English is their first language for us in the UK, and they can benefit from the innovations in healthcare that they're being offered. And that actually doesn't often benefit those that you really most want to target. So what we've started to do a lot, actually not at my centre, but a colleague does this at another centre in London, is if you got rid of all your questionnaires, what you would want to look at is, one, a questionnaire that maybe just very simply looks at complexity, or a way of grading how complex someone is. Maybe they have at least one comorbidity that's not HIV related. And then you also want to look at some measure of patient activation. So we use a PAM score to see how health literate someone is, how well they can navigate their own health journey. And, if I've got someone that's very health literate, very activated and complex, that's okay, because they'll seek out a dermatologist. They'll bang the door down to see a psychologist who can help them with their cognitive problem. The place that you want to focus your biggest attention is the people that are complex with low activation. And those people are the people that need some help with care coordination. They are precisely those people who fall between the gaps that have been spoken about in this discussion. They forget to go to their cardiology appointment. They can't afford to eat healthily. They don't exercise as they should. Maybe they drink too much alcohol, and managing their healthcare journey is just too much. So if you're focusing your attention as HIV clinicians, and I agree with Giovanni as well, training is imperative, but we're hoping in medium and well-resourced settings that we won't have too many new people with HIV coming into the pool. So maybe it is our responsibility. If you, as an HIV clinician, you really understands the stigma, the isolation that someone might be living in with low patient activation, low health literacy, low agency, but high complexity. Those are the two questionnaires that I would still use. Those are the two screening tools that I would use, because if you can get those people and focus your attention on them, those are the people where you're really going to make tremendous impact in terms of physical well-being, quality of life, and indeed life expectancy. Now, then if you've got the time, you can move back to those with low activation and low complexity, but the high activated people, the health literate people, can probably navigate. I'm not going to say we're going to let them go, but they will navigate some of their own health journey themselves. And so I totally agree with not having a siloed approach to organ specific disease.
Yeah, one thing that we haven't touched upon either is the role that rehabilitation can play and the role of physiotherapy and a focus on occupation, right? What's so important to people in community is, can I be the grandparent that I want to be? Can I still live by myself? Can I go grocery shopping and get my groceries home, right? I mean, that has nothing to do with, well, it doesn't have nothing to do, but it's not about specific diagnoses. It's not about more medicine or more, it's about how can I do these things, or how can I find support that will enable me to do these things?
Gosh, and the single most useful intervention in our frailty service was having an embedded physiotherapist. That was the thing that was most appreciated by our people that were coming in with frailty syndromes.
Kate, I agree with you completely. In geriatrics, and hopefully increasingly so in HIV, we say that we care less about what specific medical complication you have, and we care more about what your functional status is. You may have, as a example I pull out of the hat, perfectly stable metastatic breast cancer, and you can be 100% functional. So the two are not necessarily, different from another. The question is, how do you maintain function? How do you avoid a decrease in function? And this comes back to thinking about, as Giovanni has said, geriatric syndromes, because mobility we know is impaired. We know that falls are increased. We know that muscle function is decreased. So having access to rehabilitation services, physiotherapists, and first identifying somebody who may have impairment in what we refer to as activities of daily living, impairment of instrumental activities that are daily living. You may be able to take care of yourself in your home, but can you do your shopping? Can you navigate, the expenses, especially if you're isolated, if you're living alone without any social supports, it becomes difficult. And can you get good food? As Tristan said, healthy food is very expensive. We know that. So again, it's transitioning to thinking about geriatric syndromes rather than single comorbidities, which leads to the siloization of healthcare, because these are really interdisciplinary. And then how do you create, the team that thinks about all these things, because one person cannot do it. So how do you create the teams, especially if you don't have access to them, if you're not working in a, academic tertiary care hospital? Well, electronically you can. You bring in people, you access people. I think people are better than questionnaires in many ways to access, to bring out these issues in people. The question is, how do you do that in a way that, makes sense to the person in front of us?
Yeah, and oh, hi, Saul. So one of the other things that hasn't come up yet, which is non-condition specific, is pain. And pain management for people who are growing older with HIV is a very under-addressed area. And I mean, I've heard that from HIV clinicians that they feel very empowered to manage people's pain in an inpatient setting. And then when it comes to outpatient pain management, they're either limited by changing guidelines around the use of certain medications, or the cost of accessing physiotherapy or drug interactions, what have you. But Saul is a physiotherapist. Yes, Saul? So I'm going to just let him interject for a minute.
Thank you for the opportunity. I'm glad, Rehab's mentioned. I'm a physiotherapist from KwaZulu-Natal in South Africa. Tristan, hello. I'm sorry I can't meet you in person. Tristan had emailed me, and I'm so glad I could make this session. And I have a sub-Saharan African person for you, but I'm not going to volunteer him in the public forum, but I'll connect you if that's okay. And so there's a lot to unpack here, but it's wonderful how sort of multidisciplinary all your experiences are, and you clearly a lot of focus on more than just medical issues. I see a lot of talk, and it's been going on for a few years now, about the fourth 90, this mythical number. South Africa, to be honest with you, we just getting a handle on the first 390s, not so well, but it's improving. There's probably a reason we don't have a history of working with people aging with HIV, for well-known reasons. But increasingly, we have more and more people aging and living a longer life with HIV, which is wonderful. But we're nowhere near the sort of fourth 90. And I wanted to ask the panel how you look. You can measure viral load, you can measure adherence, you can measure outcomes and tests in percentages, but the thing of quality of life, it's so difficult. Obviously, as a physiotherapist or physical therapist, as I say in Canada, I'm very focused on sort of function and quality of life along with my rehab colleagues. But even amongst us, there's a whole lot of debate about how we measure that. It's not a number you can just test. There's so many cultural factors. You spoke about language. In Malaysia, we have 11 official languages. In South Africa, so it's a difficult question. But if anyone wants to sort of have a go at how we get a handle on quality of life. Thank you.
Do you want to respond to the pain question too?
I actually have not much to add to the pain because we don't actually assess that in our setting at all. It's either done by the anesthetics or the geriatrician. So I actually have no experience of how the assessments will be done in our setting. Yeah. With the quality of life question, that's a difficult question, and we haven't worked that out. We have spoken to the community and asked them to give us an itinerary of what they would consider as a good life, a quality. What would they want to preserve, as they grow older? And there was a lot of variation. And we were initially intending to use that information there's so many quality of life tools out there, and each measures different aspects of life, or activities and so on. And we were intending initially to use that information as an itinerary to decide which tool we might then implement in clinic, something that's done every year or routinely. But what we heard was there was so much of variation. Each one has got a different aspect of what they would like to be most engaged in. But two things that came up that were quite consistent, was community involvement, and they wanted to have a sense of purpose. Everyone said that, which to some extent gave us some idea that perhaps we really need to engage community as our patients get older, get them involved to volunteer and help other patients, share the experience and so on. And the other thing that came up was stigma and discrimination, where they felt that, if things could be, something could be done to reduce that aspect of life, that would really help.
I want to pick up quickly on two things that you brought up. One about pain. You may not make decisions on an outpatient basis, but we sure need your help when it comes to toxicity of the medications. So your role is extremely important. And the other, you mentioned function in terms of quality of life. And I want to give a little shout out tomorrow to Giovanni, who's going to talk about intrinsic capacity as part of a much broader way of looking at functional assessment, functional ability, and how it ties in with quality of life. And I think Giovanni's going to be talking tomorrow at 12 o'clock here. And we'll hear a lot more about that tomorrow, which is a new emerging concept of how to roll in together many of these disparate areas.
I just wanted to respond and pick up on what Sol said. Australia has developed a quality of life tool called POSQUAL, and it actually measures functional, social, physical domains. And what we are doing, what we've started to do is to invite our patients to complete this 13-question questionnaire the week before their clinic visit, so that when they come into the clinic, that their responses to the questionnaire have been downloaded onto their electronic medical record. And then we've developed some different responses to where there are deficits, in which community plays an enormous role. And so that's what we're doing, trying to do as far as quality of life goes.
So just acknowledging that we're in the last 5 minutes or so, that went by really quickly. I just want to see if anyone back here has any questions, comments, concerns. Yeah, James.
Hello, it's been very interesting. I just from a Canadian perspective, I guess, and as a person living with HIV for 25 years myself, who works in HIV research, you know, I look at my own personal experience with, like, I don't think I've seen my HIV specialist in 15 years. I don't know. My GP, who's a GP who looks after a lot of HIV patients, I see him. I like him very much. But you're talking about, you know, siloing. I feel like I have to sort of triage my own, oh, I'm feeling this way or that way. I tell the doctor, they say, well, go see this specialist or go see that specialist. I go to the specialist. I have to re-explain everything that's going on. But I don't know where, as I age, like who's looking out for me. Like I don't know whether my GP is really putting all the bits and pieces together and then has a plan for me. I feel like that plan I have to come up with that plan. And I don't know. So anyway, I just wanted to make that comment because it sounds like there are things going on that I'd like some of that.
Yeah, it's almost like we need to adopt that patient-centered medical home model where like someone brings all the information together, someone that's their only thing that they do, because if you're seeing people every 10 minutes, you don't really have time to pull all that information together. Tristan, did you?
Yeah, I think that's precisely my point. Everyone can see a specialist, including an HIV specialist for any condition, but it feels to me like someone, not just someone with HIV, but in this case with HIV, someone should always know not only who their specialists are, but also who's coordinating their care. In the UK, that will generally be assumed to be a primary care physician, but actually for most people with HIV, that doesn't work. If you move into some other disease areas, let's say, for instance, you have a psychiatric condition or a cancer, your oncologist or your psychiatrist will usually become the coordinator of your care because that's your primary problem. And in the same way, for me, it feels like people that are getting older with HIV, it's great that James has a great relationship with his primary care physician, but maybe the primary care physician doesn't know he anticipates that they're their coordinator. And actually, maybe it'd be good if the HIV clinician got a bit more involved. And it kind of feels like alongside knowing who your specialists are, you need to also know who that person is who's at the middle of things, who helps you coordinate. Now, often you'd love that to be the individual, but it would also be nice to have a named person who can support you in coordinating things when they're not clear.
It would be good if that person also knew who they were, because then they would know that that was their role. Giovanni, did you want to add something?
I don't want to scare anybody, but actually I want to point out an issue that I have now. And so far, at least in my country, ID physicians were the point of care in which actually all the specialists should refer to, or actually I'm the responsible to put all the different specialists, let us say, prescription into a plan. Okay. The point is that there may be people that at a certain time need home-based care, nursing home. And actually, this is a very, very critical point. In the past, nursing home rejected people living with HIV, assuming they were not prepared, or even there may be had risky behavior inside nursing home. This is no more the case, but actually something different is happening. Whenever a person living with HIV enter a nursing home, most of the time, I'm not able to see him anymore. Okay, and so the point is that these nursing homes are somehow let us say, sufficient, and we lose patients that have been followed for the previous 30 years. And so I think this is an area we need to concentrate more. And so is the nursing, let us say, support enough just because we are prescribing antiretroviral therapy? But where is the model of being patient-centered, but having all the history of the patients for the past 30 years when the person gets inside nursing home?